let's see, you told me this morning. Hold on, so how do I don't see anything? Let's see. Okay.
And then if you just put it in present mode, I can let you know if we need to switch the display mode.
Do I need to switch?
That's perfect.
Is this the right one? The right mode for people to see?
Yes.
Just fine, right?
Yes.
Okay. So we're gonna finish this year's session on uveitis, went by pretty quickly with the Y dots. And Y dot has always been fun for us because it constellates a number of syndromes or finding that we still yet, frankly, do not have a very clear understanding. So let us see how we can try to make sense out of this. Again, our disclosures here very much similar to what I described this morning. When we talk about Y dot syndromes, there's a number of entity, in particular 6 in general, for us to be able to consider. That include birdshot, multifocal choroiditis and panuveitis, that MCP, pontic endochoroidopathy, PIC, multiple evanescent Y dot syndrome, that's MEWDS, and the acute posterior multifocal blood clot pigment epitheliopathy, AMPPE, and then the last one is serpiginous. So there is this 6 usually constellate the Y dot syndrome. There are other that you can fit into as well, but they're usually rarer. So we usually consider this as an aspect. That's what we do when we talk about Y dot. Okay, so let's start with a case here. So this is a patient that is 68 years old, and the patient has a history of prostate cancer and remission right now. The patient then presented to us in this aspect here that have a visual acuity of 2100, and then in the right eye and 20/80 in the left eye. Slit limb examination were very much quiet, and the fundus are shown at, you should see there an aspect here. So this is his fundi, the right and the left eye in this aspect from here. This patient is from a relatively older era, so that's why I don't have the wide angle yet for this patient from here, from this thing. But this is his right eye and this is his left eye. Anyone see any diagnosis yet? Okay, if you you can speak, so if you speak, just speak out if you feel like the answer to this one.
Serpiginous.
Serpiginous. Okay, you see the key thing to call serpiginous is because of what? What's the key feature that causes serpiginous? What does the lesion has to look like? The key feature of serpiginous is that the lesion need to connect and start from the disc, right? So that will connect it out to spread it out. Otherwise, you can see other aspects that may not be. So the connection has usually, you cannot cause something serpiginous without having the lesion in general have somehow connected to the optic nerve outside from the optic nerve in here. So this is the fluorescein angiography of that aspect, showing the hyperfluorescence at the border in there. So the question would be the likely diagnosis. So serpiginous is one aspect. What is the other thing that you can look at from the color photograph along beside the serpiginous? Dr. Ngao. Natasha, what else you think here?
Maybe MCP.
I'm sorry?
Maybe MCP.
MCP, so multifocal choroiditis and panuveitis. The lesion in MCP are a little bit more discrete. They're usually not well connected like that. So MCP is on a differential Y dot, but in this particular patient is probably less likely because the lesion are different part.
TB, sarcoid, syphilis.
Sarcoid and syphilis, okay. That certainly can possibly. Go on.
TB-related choroiditis?
TB-related choroiditis. So that if you from the endemic area, right? So definitely in the Western world, we may think of serpiginous. In the Eastern Worcester in India, they may think that many of these cases are related to TB. So the other thing on the differential diagnosis is MP. If you think of the cases of MP that will look like this. Now, if I mentioned already serpiginous and I mentioned MP, so what would be the third one on the list? Ampiginous. So the combination of those two together would be ampiginous, okay? So that would be where the feature look like both, and that sometimes they may become overactive in one point and not so much. So ampiginous is another one in here. Other thing on this list would be a posterior scleritis that actually that have occurred chronically and not well treated. Toxoplasmosis is only when it's extensive or on the call. And as we mentioned, tuberculosis is definitely on the differential here. So Serpiginous Choroiditis in certain epidemic group versus tuberculosis in another group, that is very important to make the distinction in there. And again, we use a lot of the hints from our patient epidemic factor of that aspect there. So the looking between serpiginous or MP or ampiginous, certainly they can be not easy to distinguish among the three of them because they can have some feature that are similar and some feature are different. So the similarity in this case is that the MP may be in slightly younger patient, but both can be at different ages. The FA and ICG pattern may not always be distinguishable between the two, and the initial clinical symptoms may have some blurriness in vision as well. And the differences would be the association with cerebral vasculitis. And which one is that?
MP?
Yes, so MP is associated with cerebral vasculitis. That is a very common OCAP question there for this aspect from there. The prolonged clinical course, which one had prolonged clinical course?
Ampiginous?
Ampiginous or serpiginous. The therapy, one of them does not require treatment, the other two should be. And so the one that usually does not require treatment is?
MP.
MP. So definitely. And the prognosis, which one have a better prognosis?
MP.
MP too. So that tend to be the case. So the reason why we do this, because when you first confront with this patient, as clinician, our trick would be to decide how aggressive do we need to treat this patient and how much more we have to push for them for the treatment there. That's sometimes not necessarily easy. So often at times we may need to see the patient more than once to be able to get a good impression of the patient prognosis course. So Ampiginous choroiditis usually have the overlapping feature between both serpiginous as well as the MP. So it's called Ampiginous choroiditis. Here is the different phases of MP, and this is courtesy of Dr. Lee Champo from Northwestern and Dr. David Saraf from UCLA here. So we have the different phases of MP that can occur in different phases of that at different stages out from there. And of course, you would be able to tell, cannot just tell by on the picture alone, but based on the history and on the clinical course for that. Certainly, we have just mentioned that for treatment, no treatment is needed in general for MP because and I'm sure some of you may have seen, patient can drop as much as 2,400 and yet still recover from that. So from MP, whereas serpiginous, once you lose vision from central macular involvement, it's really impossible to recover the vision at times. So no therapy is required in most cases. Regional or systemic corticosteroid may be considered in severe bilateral disease or loss of central acuity, and that more of a, in a way, the last resort attempt. Some of us still do not believe that MP need to be treated. So along with really confidence that that's not serpiginous, we usually don't. The prognosis is good. 80 to 90% of the patient recover with visual acuity of 20/40. Here, the treatment of serpiginous, on the other hand, will require immunomodulatory therapy. So IMT is definitely required for this. In the literature, you will see that you have an option of either using triple therapy that includes cyclosporin, azathioprine, and a touch of prednisone. So that's the triple. Or if you want to go down to a double, then you must use a cyclophosphamide or chlorambucil as an alkylating agent, plus a little bit of the steroid to go along with that. Now, other colleagues, for example, Dr. Mitchell Opremchek from Ohio, has proposed that this may be having to do with some viral stimulant. So at times you will also see patients that being put on Bactrim, for example, for the treatment of serpiginous of this aspect, or sometimes you consider herpes, although those things usually need to have threshold herpes that you need to be able to determine the organism before you move forward with such aspect in there. The prognosis of serpiginous is quite progressive and can be quite medically resistant, oftentimes resulting in permanent scotoma or loss of central visual acuity if one doesn't manage them properly in there. The vision is guarded for that, for example, and one of the problems with the serpiginous is that CNV may occur with that aspect, and so the vision can drop and quite a bit. This was quite significant in the era where we did not have anti-VEGF therapy for CNV. Nowadays, when we have that, the prognosis is a little bit better, but again, we don't want to wait until CNV occurred because that's when we may lose the vision for the aspect from there. Now, this patient is the patient I started with you, so he has Serpiginous Choroiditis. Beyond what I just mentioned of the treatment in there, can anyone think of other treatment to deal with this patient or to manage this patient with bilateral disease? Okay, let's see how I did it. So this patient was started on prednisone and cyclophosphamide. I used the double agent. He was unable to tolerate it, especially because of the cyclophosphamide, and he used to come in. So because this is a long-term course, I started this patient on oral cyclophosphamide, and he definitely could not tolerate that as well. So then I moved to the triple agent aspect, using agent that were less likely to affect him. That would be prednisone, cyclosporin A, and mycophenolate. So I use the triple therapy regimen right now, hoping that it was able to get rid of the side effect of the cyclophosphamide. Here, he was not able to tolerate it yet, and in this particular case, his blood pressure really becomes significantly worsened, as well as his creatinine levels start to rise because of the cyclosporin A. So anyone have any other suggestion? Perhaps one can consider, for example, right, perhaps one can consider a biologic, although it was not available well at that time, but certainly perhaps something like along the line of infliximab and a prednisone will help. But what else, what other option can we have here?
Ozurdex implant.
Ozurdex, good thinking. However, Ozurdex is not long enough to manage this type of patient. Ozurdex is only about 4 months or so in this thing. So usually we know this thing take a little bit longer, but you're in the right track. So what I did was I do bilateral implantation of the fluocinolone acetonide here. So this is the Retisol. This case was about a while back then. So at that time, we did not have the fluocinolone acetonide insert, the so-called UTIC at this moment, or Iluvien outside the US. So at that time, because he could not, and I remember this patient quite clearly, his wife was one of the congresswomen there, and it was really, really hard because she could not tolerate any of the systemic part. So that's why I decided to do bilateral implantation of the fluocinolone there, and subsequently have cataract surgery. So 2 years after presentation, his eye was quiet in this aspect. From there, the chorioretinal lesion is still there, but it's no longer active. Visual acuity 20/40 in the right, and about 20/20 in the left. Because as you can see, if we were to do a visual field, yes, we will have some field defect, but fortunately, we've been very aggressive and make sure that the central foveal center doesn't get involved, and therefore we able to maintain the vision, okay? So great, let's go on to the next set of cases here. So this time is a 26-year-old Caucasian woman who present with blurry vision, no medical history, examination 2030 and 2020. This is the fundus. The diagnosis is young woman,
MEWDS.
young woman, chorioretinal lesion, very well defined, mainly in the posterior pole.
PIC?
Yes, PIC, pontic choroidopathy, especially when, oh yeah, I also mentioned there, myopia as well. So woman, young woman, myopic, mainly lesion in the posterior pole, pontic choroidopathy, top of the list, okay? So this aspect from there. And this is the lesion that we see. The lesion mainly stay within the arcade, mainly this aspect from that. So what about this one? This one is the but this time it's a young man, blurry vision in both eye, known ocular disease, and it's 2025. This is his lesion. What is this diagnosis? Again, okay, so lesion mainly in the posterior pole between the two arcades, correct? So again, with this lesion as well as there, the diagnosis here, what would you think? They keep that in mind. Now let's look at the
MCP.
The third case, a 32 years old Caucasian woman with myopia, blurry vision. So also myopia, but this time 2030, 2022, and this is her lesion though, on the other hand. So this is quite different, right? Myopia also too, but the lesion here are not punctate, or not clear chorioretinal lesion in this aspect from there. So you have a series of 3 patients, relatively young, or under the age of 50. And so you have the patient, the on the left, all the way on the left, the lady, the one on the right is the man. Both have lesion in the posterior segment. And this would be both considered to be have PIC. Lesions are mainly in the posterior segment between the arcade. On the other hand, the diagnosis for this one would be MEWDS. This is multiple evanescent white dots syndrome in this aspect from here. And you can see they're white dot, but they're different type of white dot. The one when we have the choroidopathy is very discrete, very there. The other one, because it's evanescent, it can come and go, so you would not be able to see. What about MCP, multifocal choroiditis and conjunctivitis versus MFC from this? So that is not a possibility, but usually from MCP and MFC, the lesions are more the peripheral retina aspect from there. So a number of these colleagues have spent a lot of time, and you will see some of this name, Dr. Lee Chempo, who's now at Northwestern, Dr. Paul Sieving, who just retired at the director of the National Eye Institute. Dr. Lawrence Yunusi is from the New York Eye Group, and Dr. Carlos Pavicio is from the Moorfield Eye Center in London. Some of these have definitely developed a lot of work onto this aspect from this condition, and you can see a lot of this thing. Dr. Lee Chempo, who first described about the multiple evanescent white dot syndrome, the reason why it's called evanescent is because it's come and go in this aspect from there. It's certainly very subtle of this thing, and it definitely doesn't have that wide discrete lesion that one see in the PIC, or for example, on the autofluorescent aspect and on the red field, you may be able to see a decision quite obvious, like we see it here from this part here. The autofluorescent also can be very helpful because it also can give you a hint of what it looked like when we could not be able to see outside, just look at the color from this photograph. Between PIC and MCP, there's similarity and there are differences. So actually, currently, John Pott, one of our third-year residents now at Bio Stanford, he just finished his project looking at the heat map, looking at the various different patterns that John is going to present, I believe, at the ASOS coming up next here, where we look at the lesion and the various different lesion subtype between these two here. So there's similarity and there are differences. The similarity is that there's a presence of this yellow-white spot that can become pigmented with time, and that can occur with both PIC as well with MCP. The location, on the other hand, is quite different in my opinion. If the lesions are mainly in posterior pole compared to the scattered distribution, usually I will label that as PIC. The presence of erythrocyclitis and vitritis occur with which condition, PIC or MCP?
MCP.
MCP, because patient with PIC, the vitreous is usually very quiet. We don't see cell there, we don't see cell in the front part. The clinical course and the prognosis can be similar because both can lead to visual loss because of secondary complication. So here's the clinical course for this. For punctate endochoroidopathy PIC, there the majority of the vision remain with visual acuity better than 20/40 if there's no CNV at all. CNV can occur 17 to 71% of the cases. Adam Gertenblit, when he was the medical student working with me at Johns Hopkins, we looked together this large series of patients with PIC, and that occurred quite often with the CNV, and the other reason that they lose vision would be subretinal fibrosis. So these two are the complications occurred within just 1 year after the initial symptom. So we need to make sure that we won't let that happen from there. The MCP and the panuveitis, they're more chronic recurrent inflammation. They themselves can also have significant visual loss as well if they have complications like CNV or macular edema or subretinal fibrosis that can occur. So both of these conditions will require attention because they can lead to problems with the visual loss aspect from there. As for therapy go, in the past, colleagues may not want to treat PIC, but we have subsequently shown that observation alone is not enough, especially if we already see a rate of recurrences. So we look at a patient that were treated and were not treated if they diagnosed with PIC in terms of the recurrence of disease. And those who were definitely treated tend to do better. That means that if you first time you see a patient whom you suspect to have PIC, you do not, I repeat, you do not need to treat yet, unless there's evidence that they've had multiple recurrences. If they've had multiple episodes of recurrences, then you want to consider treating them to make sure that they don't have more complication afterward. On the other hand, MCP in general usually require treatment with this aspect from there, and a different group has shown that it would be good if you start to treat them in the early part of the disease so that they can help to maintain the vision from that aspect. Certainly when you have CNV, then you want to use the various ways to control the CNV for that from there. So management of PIC there. So this is case one. This is a case of the woman from this. She she at that time was being treated with mycophenolate, which we have found to help to decrease the rate of recurrences and the dose being tapered, and she's maintained it. She's currently living in San Antonio, Texas, and she still fly to Palo Alto to see me, and we have been able to preserve her vision over a decade now. We have been able also to manage her and hold the IMT for a certain period. So the patient have now been able to have 2 children during her course of disease, and yet at the same time maintained her visual acuity. So the treatment definitely helped to decrease the risk of recurrences once that had been shown. On the other hand, this man's case too is from Philadelphia. So in this case, he was treated with oral prednisone and mycophenolate. The lesion become more active with increased visual disturbance and prednisone's taper. So in my opinions, in my experiences, the patient with PIC, if they are women, which are more common, they are a little bit easier to manage. But in the number of patients with PIC who are men, and they're much fewer in between compared to women, in my experience, they're much more difficult. I certainly don't have enough of the data to definitely indicate that gender matters here, but there seems to be a difference in the way that PIC respond, whether it's occur in men or women. The third case that we show is the case with MEWDS, and for that, as I mentioned, the lesion often not pigmented. The spontaneous recovery is usually within 2 to 2.5 months for this, and it doesn't tend to recur. So it's usually, we usually don't need to treat that with this aspect from there. And so treatments right now, again, we don't have any known therapy for this because it usually will settle down itself. Okay, now let's move to the third set of group of disease here. So this time the age shift now. So this time as an older group, 69-year-old Caucasian woman with arthritis in this aspect here, and this is her finding. So the diagnosis here is Price.
Histoplasmosis?
Say it again.
Histoplasmosis?
Histoplasmosis. Not quite. The lesions are not punctate and are not at discrete out from there. So what other thing go into this list?
Answer.
Price or Lucia? No. Or Natasha, anyone?
Answer.
I'm sorry? Azure. So that's a diagnosis. Usually in my experience, those that can be possible. They tend to be mainly located in the peripheral retina, but certainly they can be in posterior segment. Azure is possible too. So let's see if we can look at more things so people can figure it out. Okay, so this is 2040 and 2025 from this aspect, right? And I'm sorry. Ampiginous, no, it's not at contiguous at that would be from this aspect in here. Okay, so let's move on to look at some more cases here. Now, this is a 62-year-old woman with hypertension and decreased vision. Again, 2060, 2025, no idiopsychlitis. And this is her lesion. Which one is this one?
Birdshot.
Birdshot is one possibility. The second one? What did I start out this morning with? Exactly. So elderly patient, creamy yellow chorioretinal lesions. Definitely that should be on your differential diagnosis as well, right? So yes, we can be aware, but we cannot miss that. So that's the thing. And what happened in this patient here? Whoever say birdshot. So if you think of this, what else? What happened in this patient?
CNV.
I'm sorry?
CNV.
CNV, yes, choroidal neovascularization. That's the net. I'm not sure we can see my arrow, but that's the net right there in the right eye. You see a big CNV net that leak on fluorescein angiography, right? So this is potentially a case of birdshot with CNV here. Okay, so that's two. And this is the third case. I'm showing three at the time here to help you to distinguish among a group of disease here. So this time is African-American man, fluid in the left eye, 2020 and 2040. Quiet fundus is looking at this. This is the left eye here, and that's that. Okay, so now let's go to all three of them. There we go. So the one on the right, other one all the way to the left, that's aspect of birdshot. The one in the middle, that's multifocal choroiditis. And the one in the all the way on the right, that's another birdshot with subfoveal CNV. So what's the difference between the two on the extreme? Why is it both are calling birdshot? Both the way all the way in the left and the way all the way in the right. The one in the right, the birdshot there, that tend to be more in the early stage of the disease when the lesions are much more discrete and that. Yet this patient did develop the complication from birdshot, which is CNV, choroidal neovascularization. The one on the right, the one all the way in the left is more likely to have been burned out already. So the lesions are less distinct, but still in this aspect. The one in the middle is MCP from this aspect there, and therefore there are multiple choroiditis pictured in there. So we see that in this patient on the right, all the way on the right, this is a birdshot with subfoveal CNV, which is a cause of vision loss in patient with birdshot. What would be the second reason why patient with birdshot lose vision?
CME.
Not D.
CME.
Should be a C, right? So it should be macular edema. So macular edema and choroidal neovascularization are the two leading causes of vision loss in patients with birdshot. And so lesions of birdshot are larger, they're cream in color, and they do not pigment in that aspect. And again, we just mentioned the leading cause of that. In the diagnosis of that, please make sure that we include lymphoma, because both type of, both intraocular lymphoma and birdshot can appear in that elderly group of patients. So we definitely want to make sure that we don't miss that thing. The birdshot is something that I believe that this time most uveitis specialists will treat no matter how the patient present initially, because what happened is that if you don't treat it, any study we look at, it will eventually deteriorate. So we should definitely stop to treat those patients well from that. How do one follow patient with birdshot? So this type of question will appear on your oral board at some point. How do we follow patient with birdshot? Fundus photography or what else?
ERG.
And what else? So the other thing we need to follow would be to perform visual field as well, okay? So visual field will also tell you how aggressive they are, ERG and color functions in this aspect, because color function is because the optic nerve will eventually get involved, and if they get involved, then we definitely don't want that to progress to significant visual loss there. So these are the cases, birdshot, MCP, and then birdshot with subfoveal. Again, if they just show you only one at a time, if you can use all your focus in that. When you look at a group of things like this, like 3 different patients here, then you can rationalize yourself why you call one or the other. And again, keep in mind that thing like birdshot, it can have the early stage or the late stage when the lesion, like the one on the left there. Okay, so in this case, the one on the left we treated with cyclosporin and methotrexate. The one in the middle, multifocal choroiditis, I just used the mycophenolate alone, and then the one on the right, we used mycophenolate, but because of the CNV, we also did intravitreal bevacizumab as well from this aspect from there. So we're almost done with this here. So certainly the white dot syndrome, again, there's several other ones as well, but the 6 common thing that we normally see are birdshot, MCP, PIC, MEWDS, MP, and Serpiginous. And again, in the category of Serpiginous, make sure that you have ruled out other things. Just like we discussed about EOS before, make sure that you rule out tuberculosis, because that can definitely present just like that as well with one. The common shared feature with all of them are that they, the demographic, many of them are less than 50, except with birdshot. The gender, we tend to have predominantly women as many ocular inflammatory diseases, for example, in birdshot, MEWDS, MCP, and PIC. The presentations are bilateral except what? Except MEWDS. MEWDS tend to be more unilateral, and they can have photopsia, they have blurry vision, and the virus symptoms seem to precede that as well. And then the differences here will be that they overlap in clinical feature, infectious versus autoimmune etiology, and discrete entity versus continuum single disease. For example, Serpiginous is more a continuum, I'm saying a more continuous lesion rather than discrete lesion with this aspect. What we can consider is whether or not, for example, some colleague would think that PIC is also a form of MCP, but in the early stage, and then eventually you spread it out to the peripheral retina. That's another discussion. And in summary, these are syndrome. We call it syndrome because we know in medicine, when we don't have a very clear answer, we don't call it disease necessarily, but it's more of a syndrome. And they have natural history, variable lesions, and different angiographic features of this aspect here. So I will stop here, and so that if you have any question, anyone that we can entertain. Okay, this for sure, no matter where you complete your residency training or where you practice, I believe that in your career, you will come across one of these white dot syndromes and this aspect from there, because it's together as a group, you will see that. And the diagnosis can be challenging from that, because we don't always have all the particular finding, and many of them, as you saw there, do not have underlying systemic disease, so you can tie it to something. But overall, if you don't know it yet when you first see it, is it acceptable if you follow the patient closely to see what pattern? For example, I mentioned with the PIC patient, you may not treat it right away, but if you see that it keeps recurrence and tend to have involved the foveal center, then definitely we should treat to prevent the recurrence of the lesion in there. Okay. Are there any questions? If not, yes. The presumed ocular histoplasmosis syndrome versus PIC. Okay, so in general, PIC are conditions that tend to occur mainly in the posterior pole. On the other hand, POHS show lesion throughout the peripheral retina, so it's a little bit harder for you to just see it mainly on the posterior pole. That's number one. Number two, we also have to understand to look at too. In order for you to consider yourself to truly have histo, you should have histoplasma antibody in your blood. So for patients who I suspect may have that, I actually test for that. So histoplasma antibody, the test is not 100%, but it does help one way or the other to help you with that category as well. Because the pattern is quite clearly, usually POHS is usually more in the peripheral lesion. It can also involve the posterior pole, where at PIC, in my opinion, is mainly a disease of the posterior pole. Okay, any other question that I can see? Okay, no. Okay, so let's move back to the last part of the situation here, where we are going to look at